I'm Dr. Anthony Cave, a Stanford and Harvard trained anesthesiologist and integrative medicine specialist, and I am shocked at just how many Americans cannot afford medications, but more importantly, how many Americans agree on something for a change, especially in politics, where Republicans and Democrats both surprisingly are very gung ho on addressing something as basic as what the markups are on essential medications. Hey, if you go to the grocery store and you want to figure out how much the markup is for a gallon of milk, you can figure that out. And let's be honest, milk is not nearly as essential as things like medications, especially for people like me who don't do very well with lactose. Medications are not only essential, but also difficult to afford for like a third of Americans. This is from Good RX here. Over 1 in 3 Americans says it's difficult to pay for the medications. And it's not surprising because, as the RAND Institute here demonstrates, we pay a heck of a lot more than any other country in the world for our medications, right? I know in the comments, you know exactly what I'm talking about. And if you guys want to comment here, I'll give you shout outs. I see here Jana is talking about unity, how rare it is to see this in the US system. And yes, Jody, I agree that lactate is good stuff. But why did both sides of the aisle agree on this? Because there is a middleman that most Americans have not heard of called PBMs, pharmacy benefits managers. They're kind of like the Thanos or the Death Stars, and then kind of blow up everything beneath them. Well, not really that way, but they have a stronghold on insurance, pharmacies, and the drug manufacturers. Too many of my patients think that it's the drug manufacturers that are setting the high prices. And while they certainly do play games, I have many videos on tactics that big pharma uses to extend patents. What makes, for example, ketamine so difficult for patients to obtain, proton pump inhibitors for acid reflux, antidepressants, albuterol, etc. You'll see the pattern very clearly from drug manufacturers is to try to extend patents on medications used for the most common medications prescribed, but they're not the ones that are setting the prices as much as you might think because of the role that PBMs have with 3 particular tactics that I put in black here. How they dictate the formularies, they employ spread pricing, and they have rebates that don't always go to the patient. We're going to talk about each of these. And if you're learning something new, please share with others because it is your advocacy that has helped both sides of the aisle in the last couple of days investigate the incredibly opaque practices of PBMs that are right smack dab in the middle of this pharmaceutical nightmare for my patients, and I'm sure for many of you listening. So the first issue is that there are only 3 PBMs, or pharmacy benefits managers, that we'll explain in more detail in a second, that really run the US show. You'll see it is actually pretty commonplace names: CVS Health, Cigna, and United Health. They own, as you recognize, some of them are insurance companies, and they also operate PBMs, pharmacy benefits managers, and they own pharmacies, giving them 3 of these bubbles that govern so much of US healthcare spending. And for that matter, a huge amount of the US gross domestic product, because healthcare is so darn expensive. So first, I want to focus on formularies because most patients don't recognize that when a doctor wants to prescribe a medication to a patient, they might not be able to. You know how many times I've tried to prescribe a medication to a patient just to find out that the insurance won't cover it until XYZ and whatever else are satisfied first, leaving my patient completely stuck? So if the doctor is not in charge of the formulary, then who is? Who is setting? Remember, the formulary is a list of drugs covered by your insurance. Well, this is in part determined by the PBMs, which influences what doctors can do and influences number 2, which is the rebates that PBMs negotiate from drug makers. So the reason that PBMs justify their existence is that they can help lower the prices that patients have to ultimately pay because they are large in number. Like I said, there's three big ones that kind of own the US healthcare space, and they can negotiate better than you or I could with big pharmaceuticals. The problem is that the rebate that they negotiate doesn't always get passed on to patients. In fact, this might shock you, or maybe it won't. The more expensive the medication means typically the higher the rebate will be that they can negotiate, which, if they pocket a percentage of, means that they pocket more of that rebate savings. Why is this problematic? Because the medication cost and the rebate amount influences the formularies, influences what I might do for my patient or what you might receive from your doctor. If this sounds like perverse incentives, you and Republican and Democratic lawmakers all agree. So, number three is spread pricing. That's the third black mark you see here, because spread pricing is this very shady practice of charging more than what you actually pay. So when PBMs, as the middleman here, they get medications cheaper from the drug maker, then they can supposedly provide them for insurance companies cheaper because they've negotiated a lower price. But the amount that they collect from insurance might be more than what they actually pay the pharmacy at the end of the day. What does this mean specifically for patients who are on generics, which is a lot of my medication, a lot of my patients? They might be overcharged generics, which then spread pricing allows for very large gross margins, especially compared to brand name prescriptions, right? You would think that brand names are going to be more expensive than the generics because they've been off patent, but not quite the case. The result of cost spreading or spread pricing, there's a USC, University of Southern California study that shows that 41% of the prescriptions that you pay for, or 41% of that, is ultimately going to these intermediaries, whether it's the PBMs themselves, insurance wholesale makers, or even the pharmacies themselves. Clearly, people need to get paid. But when one out of every $5 that's spent goes towards the pharmaceutical distribution system that includes PBMs, it begs the question of what kind of transparency is there over these top three dogs in the game. And when they own both the insurance and the pharmacies, like United Healthcare or Optum RX, you own a large vertical stack. You start to look a lot more like Thanos than you may have otherwise. So if you have felt that there's price gouging going on, let me know in the comments. And I'm going to now jump into our live Q&A. And I agree with Patty on here that transparency is important when it comes down to patients' lives, when patients cannot afford medications that they need, either for acute or for long-term care. And I gotta say that most of us don't advocate enough. All of this House investigation and the practices of PBMs demand more transparency is because of folks like you that wrote to legislators about how you couldn't afford your medications, and your voices have maybe for once ever actually panned out to mean something helpful and useful, which is why it's so important that you continue to advocate for yourself, not only in the doctor's office, not only in the face of gaslighting and people disempowering you at the doctor's office, but also with the bigger powers in healthcare, like the insurance companies, the PBMs, and this is where legislators can make a difference. Freddie says, price fixing, plain and simple. Our cartel's not illegal. Well, I don't think that you're too off on this. Candy, would be cool to know what other country, how other countries do it. Is it the same? No, it's not, Candy. They, for better or worse, have fundamentally different healthcare systems by and large that are not as privatized as the US. Privatized healthcare has benefits, has detriments, a much bigger discussion than what we're going to go into today. You're so welcome, Patty. Jana, good to see you. The best thing is to transfer off on RX meds. Well, I'm a big fan of natural and nutraceuticals, Jana, but don't be fooled into thinking that nutraceuticals are necessarily any less incentivized to take advantage of vulnerable patients. Coming from an integrative doctor here, I'm all for holistic natural care, but there absolutely is far more to the nutraceutical game than most patients are aware of. Lisinopril is one of many medications that may have increased in price depending on where you live in the United States, depending on who your insurance is and how the PBM is choosing to modulate it. Once again, you're so welcome. Sandy, legislators in Utah won't do anything. Well, legislators in DC are making something happen here. I think we're going to see some changes based off of just the last couple of days. I thought my copay of $4 was bad. Now I see it's not. Gabby, depending on the medication, it may or may not be bad, but hopefully it's not something that you have to decide between your $4 copay and getting groceries, which is where a sizable number of Americans appear to fall, especially the elderly and those who are retired, maybe on Medicare. I hear even MJ dispensaries overcharge, driving illegal growers absolutely CC. In San Francisco, where I practice, it has gotten so controversial that dispensaries are threatening to just sell stuff out of the back door for that reason. Tammy's inhaler was covered by our insurance. I'm happy to hear that. There's a difference between it being covered and there being a large copay. I hope your copay was not very high. And greed is pretty difficult to disentangle from the US healthcare system. You are definitely right. Silver Bells, I'm curious specifically, what have you been there on? And Heidi, so good to see you. Linda, I remember that you were so kind to me before my gallbladder. Oh my goodness. I'm so happy to hear that your gallbladder surgery went well, Linda. James Brown, I asked my oncologist why he chose the particular immunotherapy drug I'm on. He said that was a drug your insurance company agreed to pay for. What if there is a better one? James, this is the fundamental question patients should be asking doctors to ultimately get that information to feed it back to legislators and representatives. What are your representatives doing if they can't even help you afford the basic medications needed for your health, survival, and hopefully well-being? Medical care is being dictated by insurance companies. Patty, what's new? Right, I don't mean backdoor sales, but of course, Wendy, I agree. Katie, hey, good to see you on. Not perfect, has downfalls, but a lot better than others. Sometimes even 770 is a lot of money to find. Katie, it's happy to see you on here. I hope you're doing well, but I agree. It certainly has a cost. Well, Sandy's talking about $600 copays. And Candy also acknowledges that Canada has them as well. You are all on the right page. Hey, Caitlin, I hope that you can rewatch this after it's done to learn more about those 3 black holes in the US healthcare system: the rebates, the price spreading or the spread pricing, and the formulary influence that these PBMs have, which influence doctors' practices and ultimately the care that patients get. Jody, good to see you. Princess Doll, not everything can be cured naturally. Please stop spreading that. Well, Princess Doll, I hope everyone agrees that absolutely not everything can be treated naturally, which is why nutraceuticals fall victim to so many of the same incentives that corporate big pharma does as well. Please don't be fooled in thinking that one is inherently better than the other. Random. Good username. Because I can't swallow pills, I prefer to get them in liquid dosage form. It's often not covered by insurance. Random. Another example of subtleties that make a huge difference in patients' lives. I'm sorry. Al Phillips, good to see you. It's hard to order a drug and the pharmacy says your insurance won't cover. Yes, because there are formularies that PBMs, possibly along with others, are influencing to help push prescribers to prescribe a certain type of medication, which may or may not have a higher rebate, which may or may not lead to higher profits by the PBM. You get the idea. Thank you, Heidi. As always, if you are learning something new, please share with your loved ones so that more people can advocate with their legislators, their representatives, to ultimately make a difference in Washington, to demand the transparency that we are finally seeing being demanded today from PBMs. Let's do 2 last questions. We are going to Capitol Hill with nearly 1 million petitions. I'm so thrilled to hear that. And my goodness, $1,000 copay. I had to work directly with the pharmaceutical company to get it paid for. I hope in the end, Bridget, you were able to get some financial relief on that. And more importantly, that you are hopefully feeling benefits from the pharmaceuticals. You know as well as anyone else, sometimes we put all this money towards a medication that might not work because the number needed to treat in the United States for many medications often is not as low as we would like it to be. It's a whole different discussion that we're going to have later on. Thank you, Emo Sir, for liking, and everyone else. Hey, remember that you have more power over your health than you've probably ever been told. And it helps if we can afford access to healthcare to be able to tap into that healing capacity that most of us have. Thank you all for the kind comments. I'm wishing you all the best. Until next time.